I think this is a case-based discussion. So we'll start off directly with the cases. This is case 1. And who will be discussing this case?
So I can discuss this case.
Oh, Dr. Gowda. So this is a 59-year-old man with comorbidities, no comorbidities, recently investigated for edema. And these are the main investigation findings. So what is your conclusion from this?
So based on investigations, we can see in a blood investigation, we can see low serum albumin. On urinary examination, we can see protein 9.2 gram per 24 hours, which is nephrotic range protein there, and a few occasional RBCs. So, and with that, nil sugar, so no diabetic cause. This can be due to a nephrotic cause with edema.
Okay, so this is what would be called the nephrotic syndrome, isn't it?
Yes, sir, nephrotic.
So main problems are with the proteinuria and low serum albumin. And yes, because there are no RBCs in the urine, we would call this a pure nephrotic syndrome.
Okay.
So what are the conditions which you would suspect when you are dealing with the pure nephrotic syndrome? So there's a lot of overlap, but
yes,
usually what are the ones which will present usually as pure nephrotic syndrome?
So nephrotic syndrome can start with like a minimal change disease.
Okay, minimal change, very good.
Membranous nephropathy can present with
right,
nephrotic. Or focal segmental glomerular.
Yeah. So minimal change and focal segmental sclerosis together, they're called the podocytopathies, isn't it?
Yes.
So podocytopathies would be one of your possibilities. Then you have membranous nephropathy. The diabetic nephropathy frequently presents with pure nephrotic syndrome. Renal amyloidosis can present with pure nephrotic syndrome. These are the ones which leak purely protein without the other. And usually when does leaking of RBCs and other cells occur? What kind of morphological change in which you will find a lot of RBCs and other kind of cells?
So any glomerular injury or membranoproliferative diseases?
Yeah. Basically, when there is proliferation.
Yes,
when there is proliferation, lot of cells and all that. And frequently FSGS also can sometimes show this, but FSGS can be pure membranous or it can sometimes have the other ones also. So these are the main conditions we're going to look at. And from this case, we will try to find out what it is. Okay? So let's see the slides. This is an extreme scanner. From this, can you say anything from this?
So based on scanner, we can identify multiple glomeruli.
Multiple glomeruli. So one thing you can say, this is a very satisfactory biopsy.
Yes,
because you have lots of glomeruli. Because you need a lot of glomeruli to really make a proper diagnosis. What else can you gauge from this picture?
So, we can't see any dark areas, so there might be less inflammation or
not much. Otherwise, I would say that this looks pretty clean, no?
Yes, sir.
Not much of inflammation, a clean biopsy. Anything else?
So,
do you think there is a lot of fibrotic areas in this or no fibrosis? So in the renal biopsy, when you find lot of tubular loss, that will be replaced by fibrosis. So you have fibrotic areas. When you have a lot of fibrotic areas, then that means that it is going into irreversible damage. So that are the cases, those are the cases which go into renal failure or chronic renal failure. So here, what do you think? Is it, showing any significant kind of fibrosis or not?
No, sir.
Not much. So, good. So this is another picture. Again, it's confirming that all the tubules are more or less back to back.
Yes, sir.
Okay, when they are back to back like this, without any intervening cells, then you know that there is not much of significant fibrosis.
Yes,
An
sir.
occasional sclerosed glomeruli can be seen in older people above 50. You would expect an occasional. That doesn't really matter all that much if you find only an occasional one. But otherwise, it looks okay. You want to go one higher to?
Yes, sir. We can't see any pretty
So
much.
we'll pick one of those. In other words, see, are all these glomeruli looking alike or are they looking different?
So nearly similar.
Nearly same. So you can sample anyone and see how it looks like. So this is what an average glomerulus in this looks like. So what is your main findings?
In this glomerular, you can see some thickening, some material
So
inside the.
you think that there is thickening of this
Yes,
capillary
sir.
wall?
So
you have to look at these capillary walls like this to see whether there is any thickening. Sometimes it's a bit tricky, you know. Early mild thickening, it is very difficult to pick up. But in this case, I think that there is definitely this is thickened and it's looking somewhat rigid, you know.
Yes, sir.
It's not showing any kind of folding or anything, almost standing rigid like this. So thickening is what you suspect. Of course, we have got to confirm with other means. What is the other point that you would like to make in this biopsy?
So, in this biopsy, we can't identify any cellular proliferation in the glomerular.
Exactly. So, the number of cells are not increased.
Yes,
That's another picture. When do you say that the number of cells are not increased? In a 5 micron section, how many cells, above what number of nuclei would you call it really increase? Let's say something like more than 75.
Yes.
If it is, then this definitely, it seems to be below that. Even with smaller numbers, sometimes in the mesangial area, the cells can be bunched together. Nuclei can be bunched together just in the mesangium. So even the total may not exceed 75, but you will find bunching of cells, you know, that is called mesangial proliferation, minimal mesangial proliferation. Here, even that is not present.
Yes, sir.
With this finding, what is your provisional diagnosis?
So, this can be due to membranous nephropathy.
Okay. So now, what is it that you want next? Most important thing that you want next is
special stain or
which special stain? I will allow you one special stain. Which one do you want?
Sir, for membrane, we should go for silver stain.
Silver. Okay. So, what do you expect in a silver stain?
Sir,
this is another picture. So, silver stain. This is a silver stain.
Yes.
Here you find what are these?
Spikes or domes.
These are called the subepithelial spikes. So, silver material seems to be just growing in between something. And these are supposed to be the deposits of membrane nephropathy. Silver stains, the problem is that unless you do it very carefully, it doesn't really come out. All you can make out is the thickening. In all cases, you may not find all the spikes. Far more easier if you have immunofluorescence to do an immunofluorescence. And what is the typical pattern of immunofluorescence in?
Well, you can see deposits on membrane.
Yeah. So what? What is usually positive? Which antibody?
The IgG.
IgG positivity. And IgG positivity all along the capillary wall. Just as you see in this picture, a granular positivity, mostly granular positivity all along the capillary wall is the typical presentation. C3 is usually not seen to that extent. Sometimes mild C3 positivity may be there. This is another picture to show a silver stain with some spikes. And in this particular case, this was the picture with IgA was negative, IgG showed positivity, C3 minimal. It can be taken as just mild, this thing. It's not really positive. 1 plus may not be significant all that much. So with this, you
Yes, sir.
put all this as membranous nephropathy. You are right. So what is the next thing to be done?
So,
You don't stop here by calling something membranous nephropathy.
etiology, we need to find etiology.
Okay, so basically, you want to know whether this is a primary or secondary. There are lots of causes of secondary causes of this thing, and there are primary. 90% of the cases nowadays, especially when all the many other causes like schistosomia, HBV, and malaria sometimes, all these are now very much decreased. So more cases are primary now, but you want to be sure. And among the secondary, one common cause is cancer. Many cancer patients sometimes develop, come with membranous nephropathy, malignancies. So we want to distinguish this. 80-20 is the ratio. And out of this 80%, 90% are due to one particular endogenous antigen. See, difference between this is one is endogenous, the other is exogenous. Endogenous means it's within the glomerulus itself, just beneath the epithelial cell. That is why the antigen is there, and antibodies are directed against that, forming complexes. This is exogenous ones which combine with antibodies and get deposited in the subepithelial location. Both at having the same final result as far as histomorphology is concerned. So here, 90% or more are PLA2, and there are some other antigens also, but these are not usually tested. But most of the renal centers now have this PLA2, phospholipase A2 receptor. Antibodies are there, and in this particular case, this picture shows a PLA2R. So C4D also sometimes can be positive in this, so usually not that. Interpreting PLA2R, what is the important thing in, because PLA2R can show some positivity in other glomeruli because it's something normally seen, no? Receptors are there even normally. But here, what is it that you say, when you say it is positive? It has to be continuous and it has to be granular, coarse granular, continuous pattern like this is what you call as a positive PLA2R result. And then you conclude that in this particular case, you would conclude that this is a primary membranous nephropathy. And this antibody can be detected in the serum also, even for following up the patient after treatment, you can really look at this, and there are a lot of uses for this. I'm not going into those details right now. So with this, I think we can go to the next case. Good discussion, huh? Gaurang?
Thank you, sir. Thank you.
So next one.
Yes, sir. So 31-year-old woman noticed reddish urine which lasted for 2 weeks, 2 months back, now complains of weakness. On blood examination, hemoglobin is normal, serum creatinine is normal, serum albumin is normal, C3 is also normal.
So what is abnormal?
Sir, serum albumin is a little bit on the lower side.
I mean, 3.4, you can just get the benefit of doubt, no?
Yes,
Okay.
sir.
There is mild proteinuria, I would say.
Yes, sir. Mild proteinuria, and there is hematuria as well.
Hematuria as well. And even grossly, in history, they say passing reddish urine. So episodically, they must be having macroscopic hematuria also.
Hematuria. Yes, sir.
So this is what you would call as a macroscopic hematuria plus some kind
Proteinuria.
of proteinuria. So when you have this kind of picture, what are the things that you will think of with this clinical picture? What would the clinician be thinking in fact?
So glomerular proliferative disorders.
Some kind of proliferation would be taking place there. Among all the proliferative glomerulonephritis in the world, which is the commonest one? All over the world.
IgA nephropathy.
IgA nephropathy is by far the most common proliferative glomerulonephritis all across the world, except probably Africa. It is much more common in Asians, very much common in far Eastern Asia, particularly China, Japan, and other places. India also, we have quite a few cases of IgA nephropathy. So that would be one of our first diagnoses. Then of course, all the other proliferative diseases also we will keep in mind before seeing the slide. So these are the various proliferative glomerulonephropathies. This is what is called an endocapillary acute proliferative or exudative, which are usually secondary to streptococcal or staphylococcal infection, which produces antigen-antibody complexes getting deposited in the kidney. Subepithelial deposits producing this kind of picture. The other proliferative disease is one in which you have both proliferation, most number of cells as in this case, as well as some degree of thickening of the basement membrane. So this is membranoproliferative, combination of both membranous and proliferation. So here the deposits are mainly subendothelial kind of vessels. Then you have mesangial areas only proliferating, and IgA nephropathy is the classic example of mesangial-proliferative. MPGN and C3 glomerulopathy are the typical examples of MPGN, membranoproliferative. Infection-related is the classic example of this one. And lastly, you have extraneous crescents like this, that is extracapillary proliferation, crescentic glomerulonephritis. So these are the ones that you are dealing with. This may be again primary or secondary. Primary means the offending agent is not known, or frequently in many autoimmune diseases, for example, SLE can present with any of these features sometimes. Any of these patterns you can get in SLE. So this is the case. Now, what do you think?
So in this,
as we said in the last case, what do you think at this power?
I can see 8 to 9 kilometers, right?
Okay, so it's an adequate biopsy.
Yes.
Yes.
So tubules are mostly arranged back to back.
Back to back. So there is not much of chronicity or other features. So that's a very reassuring thing when you see a renal biopsy, you know, that there is no features of fibrosis and going towards renal failure. So these are the things that are reversible in that sense frequently. Okay, so that's one of the things. Some degree of inflammation is there.
So interstitial inflammation.
Interstitial, you have some pockets of inflammation you can see here.
Yes.
Okay. And what would you think of the size of this glomeruli? More or less normal?
Yes, sir, normal.
Okay. Here again you see some inflammation, interstitial inflammation. There's one sclerosed glomerulus you see here.
Yes.
Okay. And
yes, sir.
another intact one. So, and here what do you see?
The tubules are dilated.
No, this. Okay, I should be using the pointer, no? So here, this glomerulus I'm talking about.
Sir, it looks sclerosed, sir.
One part of it only. See, this part is sclerosed, this part is normal.
Sclerosis.
So there is segmental sclerosis in this.
Yes, sir.
Okay. So my
Yes.
okay. Here again you find segmental sclerosis here.
Yes, sir.
Another glomerulus here, and here, one large glomerulus. How do you describe this?
So this glomeruli, we can see capillary loops are patent, and the mesangium shows 4 to 5 mesangial cells, indicating mesangial hypercellularity, and the Bowman
Right.
space
So
is clear.
that's the point. See, mesangium. This is mesangium here. So when I use the pointer, I can't seem to be able to get back easily. You know, see. Can you see this? 1, 2, 3, 4, 5, 6, 7, 8, 9, all bunched together in the mesangium. This
Yes,
is
sir.
mesangial proliferation.
Hypercellularity.
This is a very typical picture that you see. And at this stage, what is absolutely necessary to make further diagnosis?
Immunofluorescence.
Immunofluorescence. So this is the immunofluorescence picture. And how would you describe this deposits?
So immunofluorescence shows a mesangial positivity.
This is a mesangial fluorescence, not capillary, as we saw in the
Yes, sir.
earlier case. These are all in the mesangium C3. Heavy
Yes, sir.
C3 deposition. You would call this C3 plus deposition of both
Yes.
IgA and C3.
T3.
Okay. And next thing would be to do a classification. IgA nephropathy, you do what is
MESTs.
known as a MEST classification. And in this case, you would, this is the type of classification that do mesangial hypercellularity 1 or 2, M0, M1, endocapillary 1, 0, 1, segmental sclerosis, tubular atrophy, you have 0, 1, 2, and crescents also 0, 1, 2. This is the classification. Here, this is, I think there's a slight mistake here. M1, it was E0, there was no endocapillary proliferation. S1 it was. I think
Yes.
we saw segmental. It was
Sclerosis.
S1 and E1, C0, no crescents. This is the type of report that we would give here.
Yes.
And the very interesting thing about IgA nephropathy, why it is so common, seems to be that this is due to abnormal IgAs being produced, against which antibodies are produced. So this glycosylated IgA molecules against which antibodies are produced are from the gut-related immune system, GARD. And this again could be due to an abnormal gut flora. This is the way, these are the things that people are looking at, why this is actually going on like this. And lot of scope for further research because this is an extremely common disease. So these aspects you have to really look at in this particular case. So thank you very much, Neha, to discuss very well. So, no, I think it was Shana's, no?
Yes, sir.
Okay, sorry. Case 3, who is discussing?
Sir, me, sir. Dr. K.
Dr. Kedar, yeah.
Sir, before you go to this case, can I interrupt a little bit?
Yeah, please.
Yes, so there is some background noise coming. I think from one of the participants. Please move to a quieter place. Try to move to a quieter place. Thank you.
I think except for the person who is discussing, others can keep it mute. Okay.
Right, sir. Okay, sir.
Kedar?
Women, followed by facial puffiness since 2 months. Blood investigation shows.
So which are the abnormal ones here? Abnormal.
There is hematuria there and proteinuria is there.
Okay.
PCR is 4.3 milligram. And
Proteinuria, is it just proteinuria? Would you say something more about it? Is it in the nephrotic range or?
it's in the nephrotic range.
Yeah, so heavy proteinuria with heavy
proteinuria.
RBCs.
And C3 is low, so there is complement utilization.
Okay. So another proliferative glomerulonephritis, would you agree?
Yes, sir.
Okay, so we are again dealing with the proliferative glomerulonephritis. These are all abnormal. See, last case we saw that C3 was normal
Yes,
as an IgA nephropathy. Here we see that C3 is low. So
yes, sir.
this is a nephritic picture with prominent hematuria with low C3,
Yes, sir.
indicating
Yes.
more inflammation than the earlier case.
Okay.
Okay, what's your immediate comment on seeing this slide?
Sir,
What really strikes me,
glomerular,
when I see this slide, something really hits at me. What is it?
hypercellular glomeruli and
Yeah, these
slightly
glomeruli seems to be really
larger.
standing out, isn't it?
Yes,
They are
sir.
very large and they are very angry looking, very, very hypercellular, large, angry
Yes, sir.
glomeruli, just standing apart from everything else here. Very much enlarged, unlike the earlier cases. Okay?
Yes, sir.
So we are dealing with a proliferative, uniform appearance, uniformly proliferating glomeruli. What do you think about the tubulointerstitial?
Sir, tubules are back to back arranged and
Yeah, you think these are normal, no? Isn't it? So again, it shows that there isn't much permanent damage. So this seems to be dealing with some reversible condition with not progression or permanent damage so far, and with very large and hypercellular glomeruli.
glomeruli. Yes, sir.
Again, you see this same picture.
Yes, sir. Very infiltration.
Pardon?
Endocapillary infiltration.
Endocapillary. See, the whole thing looks really solid. It looks solidified, more or less. Earlier, once we could see the capillary is very much open in all the other earlier cases, membranous and IgA nephropathy case that we discussed. But here, this seems to be very solid, which means that the cells inside the capillaries are also proliferating, you're making it a solid appearance. Okay? See, this is a higher power, showing almost a solidified appearance, which is due to endocapillary. Any other kind of cells are seen along with this? All these irregular cells, these are, what do you think are these cells?
Neutrophils, sir.
Neutrophils. So you find also neutrophils, a sprinkling of neutrophils in otherwise solidified kind of glomerulus, solidification due to endothelial proliferation. Or this is called endocapillary proliferation, inside capillaries. Inside capillaries are the endothelial cells. Okay, so with this appearance, what is your diagnosis?
Sir, it could be diffuse kind of proliferative glomerulonephritis.
Proliferative glomerulonephritis. Proliferative and
mostly
exudative.
post-infections.
Exudative because of neutrophils.
Proliferative and exudative.
Exudative. So what is the most common cause of such an appearance in a renal biopsy?
Sir, meaning diseases like IgA or lupus nephritis or
We will look at
vasculitis.
we will look at the IF. You want to see the IF also?
Yes, sir.
This is the IF in this particular case. Again, capillary pattern, very much granular. Capillary, both C3 and heavy deposition of both C3 and IgG. Here it was 3 plus IgG, C3, 3 plus. C1q is also 3 plus. Granular capillary pattern. So what does it tell you, C1q?
Sir,
It's a classical pathway of complement activation, isn't it?
Yes.
So with this picture that we saw and this IF finding, what could be the most likely cause? What are the age of this patient?
Sir,
In my
55 years.
student days, when I was a MBBS student, this kind of picture, of course, you wouldn't see renal, one would never see renal biopsies in such cases, used to be very common among children. Acute nephritis, post-streptococcal glomerulonephritis producing this picture was very common in children because of it used to follow throat infection, and frequently in our place because of infected scabies was followed by this kind of picture. But now this is extremely rare in our population among children. This is, of course, some parts of India, this is still there, but many parts, this has become less now. And we see more of these cases among adults now. And among adults, what are the precipitating factors for such a picture? Again, various infections, among which diabetic patients frequently have this kind of acute exudative glomerulonephritis in many of these diabetic patients. So this particular case was diagnosed as diffuse proliferative and exudative glomerulonephritis, most likely infection-related glomerulonephritis or IRGN was the report. Of course, the patient would have to be further investigated for the cause, whether diabetes is the cause or some other cause will be needed. So this is how we would report this particular. And of course, you would add that there is no much tubulointerstitial damage yet.
Yeah.
Okay?
Yes.
Okay, thank you, Kedar. Good discussion.
Thank you, sir.
So, who is next?
So, me, Kiran.
Kiran.
Yeah. The case 4, 70-year-old woman with fever and high-colored urine for 7 weeks and generalized edema. Blood investigation showed patient is anemic with HB 7.7. Serum creatinine is 10 milligram, is elevated with serum albumin, albuminemia. Serum C3 is normal. Urine showing 3+ proteinuria, no glycosuria, and hematuria is present. RBC 12 to 15 per high power field.
So, what would you conclude from this? What are the abnormal things here?
Increased serum creatinine.
Yes. Along with proteinuria and RBC, both protein and RBC leaking this much means that there is some severe damage to the glomeruli. Would you agree?
Yes, sir.
So this is a glomerular disease. I would say that this is a glomerular disease. But the whole problem here is that within a matter of 7 weeks, very rapidly it has deteriorated, and serum creatinine in this now 10 milligram. Almost like a acute renal failure kind of picture. So what would you call this clinical picture? What do you call this clinical picture in which in a matter of weeks a patient goes into renal failure after having high-colored urine and urinary symptoms going into rapidly progressive. This is what is called a rapidly progressive glomerulonephritis. So this is rapidly progressive glomerulonephritis. This picture, when you get that, what are the possibilities?
Crescent.
Okay, we'll go to that. Okay. So let us see this. What are your impressions on this?
The two linear
I'll
causes
show you
renal
the
tissue.
higher powers later. Yeah.
So, this section is showing two linear causes of renal tissue enclosing glomeruli and tubules.
And what do you think of the glomeruli? Are they enlarged?
Yes, sir. The Bowman space is obliterated.
They seem to be bigger, no?
Yeah.
So enlarged glomeruli are there, yes. And tubular atrophy, there seems to be some dilated tubules.
Tubular
There
atrophy.
seems to be some tubular atrophy. I wouldn't like to use that word because many of these things are reversible, but there definitely seems to be some tubular loss, at least temporary tubular loss is there. And here, this seems to be RBC casts are there. See, look at this. Some of the tubules contain RBC casts. some dilated tubules.
So could
When
you
you
please
see a
use
bunch
the
of
razor
dilated
pointer?
tubules, it may be due to some tubular loss, some edema. Okay. Some space in between, edematous, some tubular loss, RBC cast here, and this large glomerulus.
So, with crescent formation.
So what is a crescent?
It's a two or more layer of proliferation of the parietal
Okay,
epithelium.
but this is
Glomerulus
much
space.
beyond that. So the entire thing is a crescent,
Thing is,
and only in the center here you find compressed tuft.
Yeah.
All the rest. So this is not a crescent actually. I mean, strictly speaking, it's not crescentic in shape. It is surrounding the whole thing. Somewhere or the other, you may be able to see the typical crescentic kind of picture. So this is just to show in high power. What does this crescents, what do they contain?
it's broad.
What are the type of cells that you see within these crescents?
So epithelial
Epithelial cells. In addition to that, there will be macrophages. There will be a lot of fibrin also.
Fibrinous.
Lot of fibrinous exudate, macrophages, epithelial all together form the crescent. And some tubular damage is there here and there, and lot of edema. See, look at this. This is edematous, indicating some acute process, and some inflammation in the interstitium, some edema. This tubule seem to be separated by edema fluid rather than fibrosis. So all is not lost as yet because this may recover sometimes. Okay, you cannot write them off actually. And this is a silver stain, again showing the crescents. You can see the tuft and crescent separately, isn't it? The black colored is the compressed tuft, and all around the light stained areas are the crescents. And how many crescents should be there to call it a crescentic glomerulonephritis? At least? At least 50%? See, again, it depends on the sampling, but I would be comfortable with something like 50% to call something a crescentic glomeruli, because many other conditions can have occasional glomeruli with crescents. Suppose you have just a biopsy with two glomeruli, one is a crescent, the other is not, then you are not really very sure. So such cases have to be sampled very well to really know whether it is really a crescentic. Of course, the clinical picture would help greatly. So when you are dealing with a crescentic glomerulonephritis, it may be anti-GBM, it may be immune complex related, or it may be post-immune, which is usually due to ANCA. So, what next? Yeah. So, anti-IgM, you will have linear immunofluorescence. Immune complex, you will have granular immunofluorescence. Post-immune, no immunofluorescence. In ANCA related, you will have to do indirect immunofluorescence to do this test. Indirect, not in the glomeruli. This is the pattern of a linear, as if you draw it with a pencil, straight lines. This is as opposed to this is a granular kind of pattern. An indirect IF with neutrophils as the target, you find two patterns, the cytoplasmic pattern of CNK and the perinuclear pattern known as PNK. Yeah. These two patterns you have indicating two different things. This particular case, this was the appearance. C3. Here, of course, it looks both, I don't know, it looks a bit linear and granular, but C3 is definitely having a granular pattern. So, this was immune complex mediated crescentic glomerulonephritis. So, Intracrustic glomerulopathy, this is the way that you really investigate all the cases. So, I think we go into the last case now. Who is discussing this case?
For me. The last case, case number 5.
Yeah.
78-year-old male, normal GFR till 2 months ago, with progressive constitutional symptoms and deterioration in GFR, the creatinine rising from 2.6 to 3.7 to 5 gradually. The blood investigation shows hemoglobin 13.7 gram per deciliter, that is normal. Serum creatinine is raised 5 milligram per dl. Serum albumin is in normal range of 4.1 gram per dl. C3 is normal.
Okay.
Urine study showed mild proteinuria. There is no glycosuria, and RBCs were 20 to 30 per high power field. So, seeing the level of creatinine being rising, I suspected some tubular injury.
Yeah. Not much of proteinuria.
Yes, not much of so.
And the RBCs are again present. So let's go back to the history. See, 2 months ago, the normal GFR was there. And now, progressively deteriorating GFR in a very short period. So, this is not a primary glomerular kind of disease. So, it's not, it doesn't seem to be a glomerular injury. So, what would you call it? What would the clinical term that maybe you would use to a case in which there is very sudden increase in creatinine?
So it is some acute
Deterioration in
process
GFR.
affecting the tubules.
Huh?
Some acute injury affecting
Acute
the tubular
injury.
portion.
Acute injury. There seems to be some acute injury. Increasingly now, many renal biopsies that we get is for this kind of condition, where patient suddenly comes with an acute kidney injury. Huh? We used to call it acute renal failure. Now people, nephrologists usually use the term AKI, acute kidney injury. So acute kidney injury, these are the different causes that you deal with. Most common would be acute tubular necrosis. Then acute tubular necrosis, you would usually have some provoking cause, you know. The patient was an accident or surgery or some other provoking thing, obstetric trauma, and followed by that renal shutdown, it would be acute tubular necrosis. So a biopsy would usually not be needed in such cases. Then acute interstitial nephritis is one case where this kind of picture can occur. And these are some of the cases in which we get biopsies. Glomerular injury, some kind of RPGNs may have this kind of picture. Again, both are suddenly increasing creatinine. So could be glomerular injury. It could be vascular type of injury. So these are the different ones, and each of these, there are different causes, you know, like vascular damage can have multiple causes. Cast nephropathy, crystal nephropathy, then drugs are one common cause of acute interstitial nephritis. So all these different causes could be there for this. So first step is to look at the morphology when you have a kidney biopsy. Okay, so this is the renal biopsy. What's the comment?
So it is a low power view showing two linear cores of renal tissue exhibiting mainly the tubules and the tubule and a single glomeruli is noted.
Glomeruli are also there.
One single glomeruli is seen. The tubules have a separation of tubules is seen.
Very good.
Indicating either fibrosis or edema.
What would the separation be due to?
So it could be either edema or fibrosis. I would prefer a high power view.
Okay, very good. If it is fibrosis, then
the history should have been a long history.
Long history. And if it is, in order to know whether it is really fibrosis or not, any other special stain that you would do? The Mason trichrome may help sometimes.
Mason trichrome, yes, sir.
Yeah. Okay. Of course, some high power, if you are sure that it's edema, you don't really need that. So here, is it due to edema or fibrosis?
So here I can see edema and some inflammation.
Yeah, you see this bluish things here. Okay, good.
Yes.
What else in between these tubules?
Some inflammatory cells are seen, sir.
Uniformly, there are sprinkling of inflammatory cells all around. Okay, mostly I think lymphocytes.
Yes, sir.
Lot of lymphocytes in between the tubules, edematous stroma, edematous interstitium, and any other cell other than eosinophil. Lymphocytes.
Yes, I noted an eosinophil and
Okay,
a
see,
plasma cell.
yeah, you can see quite a few eosinophils spread in between this. So with this, what would the conclusion be? And not only that, sometimes you see, you see very nice some lymphocytes also get infiltrating the tubules you find in lymphocytes. This is tubulitis. Tubulitis, usually you look for what kind of biopsies? The transplant rejection, that's one of the things that you always look for. Similar to transplant rejection, you can see this, the inflammatory cells getting into the tubule sometimes, even in these cases. Okay. So here again you find some eosinophils, edema. See, this is a eosinophil infiltrating the tubule. Some tubulitis is there. Eosinophil. So what is the importance of eosinophils in this case? These are the causes of acute interstitial nephritis. Drugs, one major cause, including in our time now. This seems to be the most important cause, drug-induced AIN. Then you have various infections which can produce acute this thing, but that will be in the setting of an infection usually. Any viral infections, you have a viral infection, along with that sometimes you develop this. So you know that it is, and frequently may not be needed, a biopsy may not be needed in many of such cases. Leptospirosis, you get this interstitial nephritis and renal shutdown, but one never or rarely does a renal biopsy in a case of leptospirosis. But the unexplained ones are the ones in which you do biopsies, and we end up with more cases of drug-induced and sometimes rarely IgG4 disease sometimes, or other things sometimes. Okay, so what is the indicator that this could possibly be drug-induced in this our case?
So eosinophils.
Eosinophils. Presence of eosinophils strongly indicates that there is a drug, offending drug usually producing that, and these are the list of drugs that can produce this. Okay, I think we stop here. So your diagnosis is absolutely right. So good. Last, I think the last slide that I show, maybe you can take it as a poll.
Okay.
The moderators, please.
Yes, sir.
I have here two cases of acute kidney injury presenting with a similar picture. The first one, anybody would like to make a diagnosis? Do I have to give it as multiple choice?
There's no need, so they can type in the chat box.
Okay,
The answers are coming.
answers are coming. TMA I can see.
Yes.
Malignant hypertension,
Malignant
yes.
hypertension.
TMA secondary to malignant hypertension. Okay, absolutely right. So this is, you can see those vessels. It is showing hypoplastic arterioles, So you have this concentric intimal thickening, some mucoid material. You can't see any thrombi within this. This can be due to malignant hypertension. Sometimes you see also thrombi in such cases. And almost a very similar picture you can get in systemic sclerosis sometimes. So systemic sclerosis, malignant hypertension with TMA, these are the features. Second one, can you type another cause of
Light cast nephropathy.
cast nephropathy? Everybody agree? So these
Yes.
are the cause
Nephropathy.
against which there is some cellular reaction. Here there are giant cells, and these casts are sometimes fractured. Here you don't see a fracture, here fracture, they get broken up. And this is cast nephropathy. Sometimes they send a case for acute kidney injury, and you find this picture, you tell them, go and look for myeloma, and they will find that there is a light chain myeloma usually producing this kind of picture. Okay, so I think we'll stop here. Thank you very much.